Hello, everyone, and welcome back to Lady Scientist Podcast. I'm your host, Jocelyn Pearl, and we have another great interview in store for you today. I chat with two women from an organization that has been doing the groundbreaking work to validate the use of psychedelics for the treatment of various disorders in rigorous clinical trials. I think that this episode will be a really important one for those of you who are tuning in because of your interest in drugs such as MDMA or psychedelics. I think that this conversation offers a perspective from the researchers, the core team that was involved in putting together these trials and validating their use. And I think that's a really important piece of the conversation around these drugs. So I'm excited to share this with you all. I also want to give a shout out to our sponsor, Kendall Investor Relations. Kendall Investor Relations is growing, and I will link their careers page. So if you are interested in joining their team, check that out below. I also want to give a shout out to our patrons, AJ and Fani. Thank you for supporting the show. And if you'd like to support the podcast, you can click subscribe, leave us a comment, go to our Patreon account and subscribe there. And we also have some merch available through our website. So thank you so much for listening and supporting this independent podcast. And I hope you learn a lot from this interview. Enjoy. Great. So I know, Alia, you asked for a bit of background on us. So I'll start with that. My background, I have a PhD in molecular and cellular biology and currently work as a senior scientist with Alex at a biotech company here in Seattle. My focus is on epigenome engineering. I've worked in a few different areas now, but mainly translational research. I invited Alex to join today because this interview was actually her idea. We were out in the mountains and talking about the podcast, and she was like, oh, you should really interview someone from MAPS. And I'll be honest, I didn't know a lot about MAPS. She is just a naturally really curious person, and I think that's kind of part of what this show is about. And so I wanted to make sure that she got to ask some of her curious questions that she had about the type of work that you guys do. So Alex, do you want to give a little introduction on yourself?
Yeah, so I'm Alexandra Croft, and I work with Jocelyn at Tune. I've been working in oncology and kind of neurobiology for the last 10 years. And yeah, I think this will be a great interview to kind of look at the other side of your work and kind of how it relates to what we're doing too. So excited to chat with you guys today. So, awesome.
Great. And Alia, maybe you can start us off with an introduction on yourself.
Sure. So I'm Alia Lilienstein. I'm a medical director at MAPS Public Benefit Corporation. I've been with MAPS for about 4.5 years now, so a little while. Maybe not as long as some of the other people, but feels like a long time. I'm a board certified family medicine physician. Before I worked at MAPS, I was working full-time as a primary care doctor in Berkeley, where I still live, and with my husband and my 3-year-old daughter. I have a background in public health and an MPH in epidemiology and biostatistics, and I hold a certificate in psychedelic assisted therapy and research. In this day and age, I also like to mention a little bit about my background because I'm a first-generation American. My mom immigrated to the US from the West Bank. She's Palestinian as a refugee in the late 60s. And kind of a stark contrast, my dad's family's been here for many generations. In fact, I actually have relatives who fought in the American Revolution on his side. So I represent kind of different perspectives and backgrounds in holding those two sides. Yeah, and like I said, I live in Berkeley with my family. My daughter turns 3 next week.
Wow.
Yeah, it's a big part of being a lady scientist, I feel like, or my current journey. Yeah.
Awesome. And Allison, could you give us a little bit of your background?
Yeah, absolutely. So my name is Allison Coker. I'm the Regulatory Affairs Manager at MAPS Public Benefit Corporation. My background and training was in neuroscience. I had a pretty multidisciplinary education, and my research really was in behavioral pharmacology, studying motivation, addiction, and stress in both preclinical models and then all the way up to human clinical research settings. So we did really truly like translational research where we utilized the insights of preclinical studies of addiction to inform what we did in the clinical studies and then took that back into the animal models. And prior to joining MAPS, I worked as a program manager for a Department of Defense funded consortium at UCSF that was looking at translational and clinical research in developing novel treatment strategies for PTSD and alcohol and substance use disorders. I'm still in the Bay Area now, and we still have a lot of collaborations with UCSF. And yeah, I've been at MAPS for about 2 years now. It's been great.
Awesome, awesome. Alia, let's start with you. Could you give us kind of a background on MAPS and what the mission of MAPS is?
Sure. So I think it's important, there's a distinction between MAPS and MAPS Public Benefit Corporation. So,
right.
Yeah, so MAPS is a nonprofit, a 501c3. It was founded in 1986 by Rick Doblin. And in general, its mission is to help create a safe and legal opportunities for the uses of psychedelics in society. You'll see that on the webpage. That's the mission. This, takes many different forms, and one of which is MAPS Public Benefit Corporation, which is a wholly owned subsidiary of MAPS. It's a corporation, but it's a public benefit corporation. And the mission of MAPS Public Benefit Corporation is to research and study in kind of a typical regulatory environment psychedelics for specific indications, following the path to approval in the US and other countries worldwide. MAPS Public Benefit Corporation also trains therapists in psychedelic-assisted therapy, specifically MDMA at this time. So that's another big part of what MPBC is up to.
Interesting. And what was the rationale behind moving the research organization into a for-profit corporation?
So that happened before my time, but it's something we certainly talk a lot about because it used to be one organization. There are a lot of things went into it. Partly, like I said, MAPS has many different things that it does. And the development of drugs in a typical regulatory model is only one of them. One of the avenues towards safe and legal access of psychedelic drugs to all who may benefit. So I think there's an important distinction between the two, that there are a lot of other advocacy and social justice related kind of things that MAPS does that have nothing to do with technically with the regulatory process or bringing a drug to market. And so it was important to make that kind of distinction. And then I think that longer term, there's a need for this drug development arm to be self-sustainable, that while MAPS has existed entirely on philanthropy for, since 1986, long time, it's a hard thing to do, hard thing to be raising money constantly for a very expensive process of bringing a drug to a commercial market. And so there's some need for some profit to be generated to make it a more self-sustaining mission.
I see.
Yeah, hence the public benefit part.
Sure.
That the profit is to sustain the mission towards legal and safe access and research, not necessarily for any other specific reason, but that is needed.
I just find it to be a really interesting structure, and like I'm curious if you've seen that model replicated anywhere, because I know of a hospital, for instance, that's looking into using something like that, like starting a biotech, internally, so that they're able to move things into the clinic, for instance.
Yeah, I I trained at Mount Sinai in New York City, which started out as a hospital and a research institution before it started a medical school. And so there are a lot of these models of various different divisions of healthcare realizing that they would like to in-house or generate another aspect to help sort of feed the circle and take what they're learning and apply it in another avenue. I'm not as familiar with this existing in the pharma world. It's quite rare to find nonprofit or public benefit corporations, I think, within the pharma world. Although I certainly haven't done exhaustive research to look and see how many there are. But my experience is that even though the field of drug development has a lot of good intentions, it is certainly influenced by the profit and commercial market.
Sure. Allison, I want to jump to you and ask, how did you first learn about MAPS Public Benefit Corporation and what led you to work there?
Yeah, absolutely. So our research group at UCSF, which had a lot of experience with PTSD and alcohol and substance use, was one of the clinical trial sites that MAPS was considering as they were expanding from single site studies to the multi-site phase 2 and phase 3 studies for MDMA-assisted therapy for PTSD. And when we agreed to become one of those trial sites, it was around the time that this consortium was ending. And as I learned about this phase 2 data that MAPS had collected, the results were more promising than anything I had seen in previous research. And to give this a little bit of context, the FDA has designated this treatment as a breakthrough designated therapy. And they reserve this for treatments that are both for serious and life-threatening conditions and that have preliminary evidence that suggests that it could have a substantial improvement over existing therapies. And so based on this data, I was just hugely impressed. And, if these trials were successful, it would have a big impact on the field. And I was really excited, and I still am really excited about the regulatory challenges of this approval process for MDMA, because it's a first-in-class treatment. Getting to this stage of drug development involves a lot of collaboration with the regulatory agencies. And I really wanted to be a part of forging this path forward.
Wow, that's really exciting. And could you give us a little bit of an update on where that program stands today?
Oh, yeah. So we have recently completed our first phase 3 trial.
Wow.
Which is huge. It is the first phase 3 trial of a psychedelic assisted therapy that has been done. We published our paper in Nature Medicine in May. So that was really exciting, a huge achievement for our entire company. All 35 years of work has culminated in this. Yeah. So the way that FDA does approval is you need two phase 3 trials, one pivotal trial to demonstrate that efficacy, and then a second confirmatory trial. So we're in the process of doing our second confirmatory trial right now, and completing all the other regulatory pieces that need to be included in our NDA package that we plan to submit in the next couple of years. So it's pretty exciting.
Congrats.
That's awesome.
That's
Congrats.
huge.
Yeah.
And so you were learning about the data and the research, you were already kind of familiar with this field, but was there, a point in time or was it, a specific job that, that you were like, I have to join this organization?
I do think that I wound up in the perfect job for me. The regulatory strategy is really cross-functional. We work between a lot of departments because everything ultimately, there's, doing the research at the trial sites and, working with the actual patients. But then ultimately, everything that we're doing in the trials is to become part of the submission package for the FDA. And so as regulatory affairs manager, I'm really organizing and overseeing all of the pieces that are going to go into that package. So it's really cross-functional and really interesting. So that was definitely a draw to coming over. And again, like I said, everything that we're doing, nobody's done this before. This is really a very different type of therapy that we're trying to get approved. And so that's a really exciting draw to be a part of.
And do you feel the current therapies available for these kind of conditions you're trying to treat, how do they compare to like what you guys are doing specifically, and what are currently available? Yeah.
So that's a really great question. So in the United States, at least, it's different in other countries, but in the United States, the first line treatments for PTSD are SSRIs. So antidepressants that, you know, people take for many conditions. You take these daily. A lot of people suffer from side effects with them, and the efficacy, it helps some people, but it's not where we might want it to be. And it is a forever kind of treatment. And what's really different about MDMA-assisted psychotherapy is the way that we have the treatment package set up. You know, it's several months. There's, you know, preparation, therapy sessions without drugs. And then you'll have an 8-hour therapy session where the MDMA is administered, and you have supportive psychotherapy during that process, and followed up by, you know, a series of non-drug therapy sessions after that. And you repeat this up to 3 times. But at the end of this few months, people have sustained impacts on their PTSD symptomology. There, you know, a lot of our, I think it was 67% of our participants in our phase 3 trial no longer qualified for a PTSD diagnosis after 2 months after their last MDMA session. And this is like, they hadn't taken it for months. It's not a daily treatment. So it's a fundamental shift in the field of psychiatry. There's just thinking about it as opposed to going from a daily treatment to taking this and not needing to continue. We haven't completed our long-term follow-up yet for our phase 3 data, but in our phase 2 studies, when we followed up with people that had been in the study a year later, 2/3 of them still did not have a PTSD diagnosis, which was actually an increase. The initial, sorry, I said that a little bit backwards, but in our phase 2 study, after 2 months, about 54% of the people no longer had the PTSD diagnosis. And at a year later, it increased to 67%. So our initial findings in phase 3 are actually a little bit better than that. And we're hoping that we will also see a similar strength of durability when we do the 1-year follow-up. So it's a very different, you know, schema than the current treatments that are on the market. And so we think this is a big improvement in both the efficacy and the safety of not needing to take constant drugs and having side effects every day.
Wow.
That's great.
That's amazing. I read the numbers before this, but just hearing you say it and like thinking about what a game changer this could be, it's really incredible.
And that's why we came to work for MAPS.
Yeah, exactly.
Another great reason.
We talk
Alia,
a lot about what percentage of people no longer have PTSD symptoms. Allison mentioned that 67% at 2 months in our phase 3 study. But Allison, I'm wondering if you remember the percentage of people who just had a meaningful
88% of the people had a clinically significant decrease in their PTSD symptoms.
Yeah, so
wow.
It's not like those other people didn't get better at all. A lot of them got a lot better. So it's a really mind-blowing and the effect size in terms of how strong the strongly we can see in statistics that the drug worked is just really impressive in this data and unparalleled in psychiatry for drug treatments.
Wow, that's amazing. Like, well done, you guys. Okay, I want to take a step back. Alia, you've had a really interesting career journey. You have a background in public health. Can you talk a little bit about some of these career transitions that you've been through and what led you to pursue a career in public health and then go on to medical school?
Sure. When I was an undergraduate at Georgetown, I was an American Studies major, and I was really interested in society and culture and how it affected and generated the infrastructure we see around us. Really appreciating the fact that laws, regulation, healthcare, things that we kind of don't necessarily think of as a reflection of societal values really are, and how can they discriminate against people or unintentionally perhaps but how do these structures then impact people and some of those underlying values of society, and how can we shift them? And I became really interested there was a public hospital in DC that was closing because it was just costing the city too much money. That was what the politicians were saying. It was a public hospital that served the Black community of DC, and it was really that community's medical home. And the idea in the politics and amongst the legislators was, let's close the hospital, it's costing too much money. And instead, we'll just give everyone who used to go to that hospital kind of an insurance card, and they can go to one of the other hospitals in the city. But those other hospitals weren't really culturally competent, and it was onerous to get your card and show up, and people didn't know where to go. And there was a big outcry from the Black community that this was emblematic of, sort of societal values about their worth in DC and their access to healthcare. And it was happening right in front of my eyes being a student there. And I became really interested in sort of this, following this intersection of healthcare and racism and societal values. And I wrote my senior thesis in college on it. And as I was preparing for the end of college, I wondered what the heck I was going to do to make a living. Because I wasn't planning on being an academic. I realized that what I was interested in kind of fit into the concept of public health. I wanted to continue studying it and kind of gain some practical skills that would allow me to shift healthcare and public health and let it reflect the values that I felt like were important in society. And so I gained very practical skills doing an MPH in epidemiology and biostatistics, lots of hours doing statistics by hand. And then I was shocked to realize that there are computer programs that do this. And the whole reason we did it by hand was so that we could really understand math. It brought out, the math and science side of me that had been a big part of me growing up, but just didn't get a lot of nurturing in college. And that led me into drug development, kind of because I was interested in how we present data and how we make therapies available and access to medications. And I worked first in vaccines and then on a pneumonia trial. And while I was working in a very nice cross-disciplinary team, I realized that the track that I was on was not the track I really wanted to be on. I wanted to be the subject matter expert. I wanted to understand the clinical medicine behind why we were designing the trials, and that would give me perhaps more leverage to help improve access and in the development of new therapies. And also, I really didn't want to be behind a computer all day long back then. Allison's laughing because that's what our job is. But I felt like, okay, I want to talk to people and help them, and then maybe I'll continue the research side of things. So I went back to school, I did a post-bac because I hadn't completed my pre-med requirements in undergraduate, and did that for a year, and then applied to med school. And then I loved medical school. It was super fascinating. I feel like I benefited a lot from having taken the time to explore other career paths. I kind of knew what I wanted to get out of it more, and had some perspective to offer a lot of the rotations. And when you're young, coming straight out of college, sometimes it's hard to appreciate the different life paths that have gotten patients into the room. And not that I was very old. I was like 27. It wasn't that, I didn't have that much life underneath my belt, more.
But still, you were in a different phase a little bit than the fresh out of undergrad
Totally. And I felt like it was my job to help teach my co-medical students that balance in life is really important, that while we're working hard and passionate about what we do, we need to take care of ourselves and nurture the fun and recreation in our lives, and remain whole so that we can really be present for the work that we're doing.
I'm just curious, because it's spoken about a little bit more these days, but did you observe any of the kind of poor practices that happen in the field of medicine as far as like intense hours and
Definitely. I used to refuse to get up before 4 a.m. because I felt like waking up in the 3 o'clock hour to then go into the work to the hospital. That was like the middle of the night. That wasn't, that didn't feel like a normal time to wake up. But there were often times where I had to be in the hospital at 4:30. As a medical student, you're more protected from like those insane work hours, but as a resident, I definitely did them working 100-hour weeks, 30 hours taking care of patients in a hospital setting where, you know, I was awake the whole time taking care of them, including in the ICU.
Wow.
I feel like every generation it gets a little bit better. You know, people, 20 years older than me in the US had it much worse. But still very long hours, yeah. And I feel lucky because I went to Mount Sinai. Mount Sinai was really focused on humanism in medicine. And in fact, they have a program for people who are not science or pre-med majors to apply to medical school. I didn't apply through that program, but it meant that there were a lot of people like me who were interested in other things, who'd majored in art or dance, or I don't know, anthropology, whatever that they were interested in. And so there was a little bit more balance, but definitely medical school still attracts many scientific gunners who are, despite being pass-fail schools most of these days, still people want to be the best and are willing to forsake most things to do it, including work even more. Yeah.
Interesting. And so tell us about your journey to MAPS and how you first heard of the organization and what led you to join.
Sure. So I first heard of the organization through my husband, actually. My husband's also a physician, and he went to UC Berkeley for undergraduate. And at UC Berkeley, there's a class called Drugs in the Brain. That may not actually be what it's called.
It is what it's called.
Is it what it's called?
I went to UC Berkeley, but I never took the class, but it's like, that's what it's called. It's been around for forever. So.
Yeah. So he took that class and loved it, and made a lot of good friends through it and learned about MAPS from it. And the professor, David Presti, was one of his letter writers for medical school recommendations and stuff. So I first heard about MAPS from my husband. Then fast forward a number of years, I was trying to get my husband to go with me to Esalen, a lovely retreat center in Big Sur where there are hot springs, and he's just not really that into sitting in hot tubs and lounging, but that is my idea of vacation. And so I saw that David Presti, his favorite professor from undergraduate, was teaching a 3-day workshop on psychedelic medicine at Esalen. And I was like, oh, this will get my husband to go with me. So we went to the workshop together, had a really nice time. He realized Esalen is great and would be willing to go back other times.
Always
love that.
But kind of started rethinking about MAPS as a result of that visit, and also found out about CIIS is starting, California Institute of Integral Studies in San Francisco is starting a certificate program in psychedelic assisted therapy and research. So we decided together to apply to it to be a part of the program, thanks to that retreat. And then as we were doing that investigation and application, I started looking on MAPS's website, and I was so surprised to find out that my colleagues from my old days doing my vaccine and trials were the people running the clinical trials for MAPS.
Wow.
Like I had no idea. So Amy Emerson, who's the CEO, was my boss when I was an intern doing vaccine trials.
Wow.
Yeah, at Chiron. And it felt like this amazing fortuitous connection. So we reconnected, and some of my other colleagues, Rebecca Matthews, who's also at MAPS, we reconnected, and we just kept in touch. And for about a year, I got familiar with their work. I was doing the certificate program, and then I started getting burnt out practicing clinical medicine full time. And I was kind of at a crossroads for myself in general, and I quit my job. I was seeing patients full time, and I was planning to join another primary care practice when I found out about an opening at MAPS, and it was for a job that I was not at all qualified for, helping run the clinical research, but a skill set that is specific to sort of the administration and operations of research, not really for a physician. But I was kind of jokingly excited, texted them saying, hey, any chance, you'd consider me for this position? And we started they said, let's talk. And so we started having conversations of what kind of role I could have at MAPS. And I came on first helping them with operations, took the plunge to leave clinical practice full-time, and be involved in research. It was a long time after I had last been in research, because I joined in 2017 and I left clinical research in 2004. So there was a lot of teaching things that I had to learn about the regulatory process. But it was really exciting to be a part of the work that I had been kind of hearing about peripherally. And my husband is really jealous because it's his passion, and he also works in clinical research, but he works for like a typical big pharma.
Oh, wow.
Oh, wow. Okay. Interesting.
That might be a good segue for one of your questions around conventional medicine. And
yeah. So I was going to ask you guys what you thought about, conventional medicine and treatments for, oncology type treatments, or like neuronal type treatments, which we're kind of working on, versus how does that play into kind of what you guys are working on, more like, would you call it holistic, or maybe prior to, that stress level being so high that it leads to these other conditions that we're working on? Just wanted to see what you guys thought about how these two different research fields integrate.
I'm happy to jump in a little bit. I think, so first of all, we're, following the same regulatory process that any sort of novel compound would follow. And so there's, while our modality of therapy is, and our treatment is perhaps unique in the world of pharma, the process is still very much the same. We're a small group, and so there is we have less resources and fewer personnel than probably your typical oncology drug that's coming to market. And I think one of the striking things about psychedelic medicine that's different from maybe some of the other drug treatments is it's seen as a catalyst or a facilitator, but it's not actually, the medicine is not doing the healing. The human is doing the healing. The person who's ingesting the medicine and doing the therapy is using these things as tools to help them heal themselves. And that's a different lens or a way of thinking about medicine that I gained from studying psychedelic medicine. And I began to see that actually applied more to other fields of medicine than I really fully appreciated before. So even in the oncology world, you're giving someone a treatment to try to kill the cancer before it kills their body. Really it's their body doing the healing. And the medicine is just kind of a tool to help remove an obstacle towards their healing, which is, the replicating cancer cells. We're still, looking at MDMA as a treatment for a disease that has progressed a lot. I mean, most of the people that we've been taking care of and who've been volunteering in our studies have had PTSD for a number of years. Like I think the average is somewhere between 12 to 15, Allison, if you remember, for phase 3. But so it's certainly not a preventive treatment in the indication that we're pursuing. But we're, the study and the results have shown that perhaps there are ways to get at the root problem and help people heal that doesn't require chronic treatment, as Allison was suggesting earlier.
Mm-hmm.
I'm wondering if that gets at your question, or if there are other parts of that question that you want to tease out for us to better respond to.
I have kind of a curiosity question, like because I've heard of physicians on this path of, healing the body and then kind of moving into, psychotherapy and healing the mind. And if you can heal the mind, you can heal a lot of things. So I'm curious what you think as far as how far reaching this style of therapy could go beyond something like PTSD that, is kind of based in the mind.
That's a great question.
If that makes sense.
Yeah, that helps to clarify it a little bit. So most of the indications that I'm aware of that were being pursued for both MDMA, for psilocybin, are psychiatric diagnoses for psychiatry. There's some substance use disorders that the FDA regulates them a little bit differently. It's in a different department, but they're still in the DSM. They're still considered psychiatric indications. So primarily those are the ones that are being pursued right now. And I think it kind of speaks to what we think the mechanism of action is. So by being able to create this period of openness based on the release of serotonin and dopamine, and there's downstream release of oxytocin, the patients are better able to interact with their traumatic experience. They're better able to interact with the therapist and create that type of relationship. One of the things that our founder used to say is anything that you can do on MDMA, you can do without MDMA. So it's the same type of therapeutic work. And it's really the MDMA is serving as an adjunct to supplement and enhance the psychotherapy. So in a sense, like the therapy is almost the primary tool and the MDMA is, working with it. So I think that's why we're primarily pursuing indications that are more in the psychiatric field.
But we're definitely interested in what sort of the ripple effects of that are. And I was, even before I started getting involved in this work, you see with people who have PTSD, for example, there's a high comorbidity of a lot of other medical diagnoses and more than the general population. And so I think what you're trying to say is by giving people MDMA and helping them with their PTSD, is there also a chance that will help them with their diabetes and their chronic pain and their blood pressure, hypertension. And those aren't the indications that we're studying, but we collect everyone's medical history when they join the study. And then part of our long-term follow-up is to assess their medical history at that mark after a year plus after. It would be really interesting to do a long-term follow-up, because sometimes these things don't change that quickly.
We're going to.
But, yeah.
It's on the list.
Because I think while that may not be the direct mechanism of action, I think that there's, there are both psychological and perhaps physiologic reasons why one could theorize that those things would get better as well. Whether it's people's PTSD is better and therefore they have more resilience and motivation to take care of themselves and be engaged in healthy behaviors and relationships, or on a more physiologic level, is there something about having high levels of cortisol that over time impact your vasculature and impact your insulin resistance and all of that kind of stuff? And I think, my theory is that I think we'll see a difference, but we don't have the data to back that at this time.
Fascinating. I had another question to follow on to that, but I have to think of it.
Well, I had one.
Okay, go ahead.
So how does I know MDMA is kind of first in line coming through approval right now, but how does kind of some of the other psychotherapy treatments, or I don't know if you want to call it plant medicine, what other options are there coming along in terms of research for people as well?
So yeah, as you said, we are definitely at the front of the pack. We've been doing this for a while. Next behind us is probably psilocybin, which is in phase 2 studies for a couple different indications right now, treatment-resistant depression. I think that they're still doing the terminal cancer. There've been a lot of studies for terminal cancer patients, the anxiety associated with death in terminal cancer patients. And a couple of different companies are working on that. There's also some folks that are studying ayahuasca, ibogaine, LSD, which is lower on the list due to some of the public perception and more regulatory hurdles. But I think because as this field has exploded, there are a lot more smaller companies that are coming up, and all of these compounds that I just listed have been around for a while. So there's not patent rights on them. So what seems to be going on a lot in the field is a lot of smaller for-profit companies are coming up and trying to develop new molecular entities that will mimic some of the serotonergic activity of these classic psychedelics to try to get a similar effect with a small new molecule that they can patent. It's a very different strategy than the nonprofits like MAPS and USONA are taking to their.
Sure. And logistically speaking, how, upon approval, upon completion of the phase 3 trial, how will you roll this out? Like, does it involve training a lot of people, or like, I have no window into this at all.
That's the multi-million-dollar question.
Yep. But you hit on it perfectly. It really, because we see this treatment as an integrated therapy where the therapy is such an important part of it, we want to make sure that the people that are providing the therapy are trained and have the education and background and support to be able to guide the patients through this process. And so we are massively ramping up our therapy training. I think each group doubles in size at least. We're at our biggest group just is in process right now, and we're currently enrolling our September cohort.
Wow.
Yeah.
And how big are the groups?
I think the most recent therapy group that's just finishing up right now is 300.
Wow.
And we, used to be most of this was done in person, and now that's not really a scalable model. And so a lot of work has gone into how to develop a training program that's virtual, thanks to both the pandemic and also the fact that we need to scale this to really be able to take care of as many people as suffer from PTSD if this drug is approved, and ensure that the bottleneck to access isn't that there aren't enough experienced and trained therapists. So I don't know that the next cohort's going to be much bigger, probably also 300, but there are, a lot of hope to train as many people as they can to, so that if the drug gets approved, that everyone can hit the ground running and start taking care of people.
And the people coming into the program, are they already licensed therapists?
Yes. Yeah, they're already licensed in a variety of different ways. And they're seeking additional training on top of that to help them be experienced in psychedelic MDMA-assisted therapy for PTSD.
Wow.
So how has the public perception kind of changed since the 60s and 70s around psychedelics, and what's kind of been your perspective on how that's changed and why it's coming back?
Well, I wasn't around in the 60s or 70s, but people are talking about this time as a psychedelic renaissance. And I think it's certainly in the culture a lot more and more acceptable. And there are a lot of things that have paved that road. And it's not actually just sprung out of nowhere. For example, Rick Doblin founded MAPS in 1986. So it's been a really long journey for him. So I'm sure for him, it doesn't feel like, oh, it came out of nowhere. He's been working on it for a number of years. I think what's happened with cannabis in this country has helped pave the road for that too. Just a movement away from drugs are bad or all drugs are bad to science. Let's study them and understand what they do and how they affect people physiologically, psychologically. I mean, that's a big part of what drives me to do the work, is not necessarily to say, this is good and everyone should use it. I don't mean that at all. I think I, as a doctor, would like to understand it, like I understand so many of the other things that have been well studied, to be able to give people informed ideas of how it might impact them. I think a big part of why the Renaissance is happening right now is because research has gotten to this point where we have a lot of information to share, and it's being generated in the way that research is typically generated, speaking the language of sort of the people in power and the way we communicate about these kinds of things. So I think that's a really big part of it.
And how hard is it to do research on these? I guess these are class 1 restricted.
That is actually exactly what I was just going to jump in and say. Like public perception is part of it, but the war on drugs was a really successful marketing campaign. And because we have all these restrictions, it has really, really made research more challenging. So it's taken all of this time to get to have enough investigators that have Schedule I license, that are willing to do it, that don't have these biases, that are, scared of being in this work that might impact their other career goals. Right now, there is a lot of extra paperwork because it is Schedule I. We need DEA licenses. They do an inspection. Every site we have to follow all of that. And I think that there's extra public scrutiny. I really do. I think that the classification of these substances as Schedule I, saying that they have a high risk for abuse and no medical benefit, has really shaped the way that people think about the perception of risk and benefit of these substances, that isn't based on data, but based on this classification, which also at the time was not based on data. When we look at the amount of harm that different drug compounds can do, and how lethal they are compared to the doses that people actually take. Some of the most dangerous drugs are the ones that are legal. Alcohol and tobacco are far more dangerous. They're much more likely to kill you than psilocybin is, or MDMA. But the way that this has been construed in the public is really different. So that I think that's been one of the challenges too. And I should also add, Alia and I are both in the Bay Area. So we definitely have a different scope here than other people might in other places of the country.
To kind of touch on that point of addiction maybe being more prevalent with alcohol or tobacco, how addictive are these kind of MDMA and psilocybin? And it sounds like maybe you only need to take it a few times and it might not actually be that addictive. Is that true?
That is how our clinical model is set up. And there's a lot of particular types of studies that we do in animals and people to assess abuse liability and addiction potential. Neither of these drugs, neither psilocybin nor MDMA, show the same type of abuse liability as drugs like cocaine or heroin. The scores on these behavioral tests are lower. Most people that are patients that take MDMA in a clinical setting, they report that their experience is completely different than if they had taken it, outside socially. And assessing, abuse liability in the clinical context is really important. And so that's one of the things that we're also working on, negotiating with the FDA as well, to really make sure that we're looking at this in the context of how this drug is going to be administered.
Mm-hmm.
What is your relationship with the FDA like?
So that is a really good question. We are really partners in this drug development process. As we've discussed, MAPS has been the front runner in developing psychedelics for over 20 years. So our initial phase 1 and phase 2 studies were developed in really close collaboration with the FDA in the early 2000s. MDMA was the first psychedelic assisted therapy to be granted this breakthrough designation status. Psilocybin does have it now too. And like I said, the first to complete the phase 3 trial, we're going to be the first to go to market. So getting through all of these steps involves a lot of close collaboration and discussion and negotiation with the FDA on all of these different components. So what pieces are going to go in our application, how we're compounding the drug, what's going to be on the labeling, what we're going to print on the capsules, which non-clinical studies we have to include. And so us getting this breakthrough status is actually a signal from the agency that they support our clinical development program. And it also gives us additional tools of collaboration and communication, a designated project manager, we get faster meeting scheduling and turnaround time. And, we have some instances where we'll disagree with the things that the reviewers say, but, we really focus on using data-driven evidence to support our positions. And I think it goes a long way to building a collaborative relationship and trust between us and our review division. And, we're all ultimately trying to use evidence-based science and supporting patient safety and access. So, we have the same goals here. So I think overall the relationship has been really good because of that.
And I was going to ask you a question about the kind of set and setting that you were talking about. I've heard that, there can be different experiences based off of, whether you're just out with friends or in more of a clinical setting, but also how do you control for set and setting in trials where, maybe it's not best for someone to be in a sterile, isolated room. Maybe it's better to be in nature doing these therapy sessions. And how do you think about set and setting in that context?
Really, really good question, and something that we, talk about a lot. The sort of typical randomized controlled trial where you're trying to make everything the same, except some people who give drug and some people who give placebo. I feel like it, it's touted as the best way to study something. And I think for a lot of reasons it is, and for some reasons it isn't, and kind of what you're describing, especially in the context of a drug-assisted therapy trial. There may, like you said, maybe for some people, being in a room with 2 therapists is not the optimal setting for them to get better, like that maybe they would do better outside, or all different kinds of things. Maybe they do better with an orange wall or a red wall or a blue wall, or there are infinite kind of variables that you could consider in the context of that. I think the premise to this question is an important one to go over, which is that set and setting are important for psychedelic assisted therapy. It's kind of one of the fundamentals of psychedelic assisted therapy. And what they mean is sort of the set is what you're bringing to that moment. What's happened and for you and for the other people who are in the room with you, and then physically what's in the room with you, what everything from the temperature and the texture of things to what they look like, whether you feel safe or don't feel safe, all kinds of things like that. So we control this to some extent, as much as one can, in the sense that we try to make it comfortable environment where people feel safe and physically and emotionally comfortable as much as it can be, given what people are processing through those moments. This is part of why we do the preparation ahead of time, the preparation sessions that participants do with their therapists is partially to do therapy and get to know each other, but really to familiarize them with the setting, have the setting be more like a home and less like a medical office, You know, if you look at pictures, and I'm sure there are pictures on the MAPS website of our trial sites, they really resemble like a nice living room, and not like a sterile medical office. And so the idea is to provide an environment where people will feel safe to really go to those deep and vulnerable places, regardless of whether they're on drug or placebo, given that that's the mission of the therapy, is to be helping them uncover these vulnerabilities and understand them better. But you know, I'm excited for it when if this drug gets approved, the opportunity for people to riff on that more, the set and setting, to you know, still maintain the same, like the ideas of set and setting and comforts, but be able to explore other slightly different environments, and for patients to have the ability to choose. Like maybe there's one prescriber and therapist office that resonates with them better than another based on what they have physically there, or those people and stuff. So yeah, we recognize that the one size fits all mentality for this is not necessarily appropriate, but that's kind of the constraint of a clinical trial. That being said, all the different therapy offices look slightly different and have slightly different setups and stuff. So it's not like we tell them all the same couch to buy and the same rug to buy and tapestry to put on the wall and stuff. They all bring their own personal sense of you know, comfort and healing and safety to those environments.
So one thing that struck me when I was looking at MAPS as a whole is how many women leaders are a part of the organization. Can both of you kind of share any comments you have on that? Allison,
a lot of enthusiasm. It's been great. I've been privileged enough to, even before this, primarily worked with, you know, female leaders, but coming into MAPS, where our gender, it's kind of just takes everything you know and puts it on its head. You know, you're not expected that, you know, the main players in the room are all women, and so many of them are here. And it's, on one hand, feels really different, but on the other hand, has also been a really comfort. Like it's, I feel like because the type of work that we're doing is really trying to, you know, heal and connect. It's unfortunately the things that women are trained, you know, to do in society. But we've had a lot of open perspectives, and in this model, it seems to have worked really well. And I know that personally, as an employee, I've really enjoyed it.
Awesome. That's wonderful.
Yeah, it's definitely a funny work conversation to be happening, that you should perhaps consider some more male applicants for positions, because you need to expand the diversity of your team and not just have women on the team. Like that's a, you know, a funny paradigm, but
that's an actual conversation that's happened.
Well, you know, you notice that in your team of 6, in your specific team, you're all women, and you're like, well, it's not like you're not going to review female applicants or something. It's just like, oh, I wonder, you know, if are there perspectives that we're missing?
Sure.
I mean, that's something we're asking ourselves in general, and it's important in this field and everywhere to be asking, you know, what perspectives aren't represented, how might they influence things in a different way, and how do our perspectives give us some kind of inherent bias. But yeah, I you know, the interesting thing about medicine and healthcare, I feel like, is it's really a lot of women in it these days. And medical school has tipped. It's more women than men in medical school now. And it's no, I wish I wasn't going to say what I'm about to say, but I think it still bears saying. Like I mentioned at the beginning, I have a 3-year-old daughter, and I feel like there's in a all women or mostly women dominated environment, I don't know, I feel a little bit more acceptance of, like, if my daughter comes into the Zoom meeting for a few minutes, or if I can't do something for childcare reasons or something like that, there's just a little bit more flexibility, or maybe there's just, I perceive more safety in asking for those things. And it's not really about that, because my daughter certainly goes into my husband's Zoom meetings too, for his work. But I think that MAPS in general has such a commitment to the whole person and all aspects of us that there's like some safety and being, you know, your whole self. And I think that, I don't know, I think that maybe that it attracts people, and especially people who feel like that other places, that's not the case.
Absolutely. I'm curious if either of you have ever faced any type of criticism or scrutiny for working in the field of psychedelics. No?
I mean, like I said, I've been here for about 2 years, and half of which has been in the middle of the pandemic. So there's that.
Yeah.
I'm not really facing many people that are not in the Zoom box for the last year. But also, you know, I do try to be really cognizant of, you know, how much time we invest in the company, and how, you know, like I said, being in the Bay Area in particular, and I'm trying to make an effort to, you know, make sure that we are aware of the backlash that there might be in other places, but I haven't seen a lot of it here where we are, and I think it would just be due to the area.
Yeah, the Bay Area bubble.
Definitely. I think I was really surprised that my parents were so interested and like accepting of it. I think, you know, they were people that I was more curious how they would react to it. But my mom has worked in drug development for a long time, and so she sees it in that way. And then my med school classmates, I feel like, you know, I was always, even since I was in New York for med school, I was always kind of like the hippie Californian. And so they just thought this as like my, you know, me continuing that trend. But as the research gets published and the conversation continues, so people start asking more academic questions, or sort of, it feels like it can be a professional conversation in a way that it didn't have that much space for that just 5 years ago. And so in the evolution of my time at MAPS, it went from I'm that, you know, fringe hippie Californian doctor to, oh, wow, like I want to learn more about the data. I might want to be a prescribed. How do I get my career on track to that, from people who followed very kind of standard medicine careers. So the sort of responses have changed, but never any like professional criticism, just sort of like, oh, Alia, that's so you that you're doing that.
Yeah. Allison or Alia, can you talk about any particular highlights or days when there was a breakthrough or something happened as a result of these studies that you could share with us?
The first one that comes to mind is the day that we got our phase 3 data unblinded for us, because it's all done, the analysis is done by third-party blinded programmers to make sure there's no bias and everything's done properly. So we had a big meeting where all of the leadership, you know, we got together, we were just waiting to find out what it is. Nobody else knew. And we're all sitting, and, you know, they go through the presentation, and as you guys are scientists, so I don't think I need to explain p-values to you, but, you know, what we need for approval, you know, is just two significant studies. So it just needs to be less than p equals 0.05. And we were hoping that we would get 0.01. And then when they put together the data, it was p is less than 0.0001. 30.
Wow.
And everyone we were shocked. It was, everybody, you know, we know how powerful it is, but it really blew everybody away to have like such a huge finding. And
wow.
You guys,
I'm like tearing up.
Oh,
That's amazing.
It wound up being like a whole day of like all our board members came by, like everybody came by, and we would like do it again, and like present the data over and over. It was a very exciting day. And then, of course, from that point, needing to write up the publication and get the publication together, and none of us could tell anyone because we didn't want to spoil them. Like, you know, you can't have pre-publication results and, you know, going through all the review process. So it was an agonizing few months, like sitting on this huge news and, you know, wanting to shout from the rooftops. So once we finally got the paper published, it was really exciting to be able to share with everybody.
Wow. Congrats.
That's huge.
Amazing.
Yeah, that is certainly one of the superlative moments that came to mind for me as well. But the other thing that came to mind is so I provide medical oversight for our phase 3 clinical trials, and I don't see patients directly. That happens at our sites, but I see all of their data, and it gets shared with me and kind of a real-time basis. So that way I'm making sure that everything's happening safely. And I also get shared with the notes from therapy sessions. And so I hear about, you know, the really horrible, sad things that happen to people, and I read them. And then I read the notes from their therapy visits. It's like just so beautiful and incredible to read some of the notes from the end of the like their time on the clinical trial, if they've been helped, because people were suffering so much, and they are doing so much better and have so much empathy for themselves, and are so grateful that they're feeling better. And it's just like such a beautiful continuous reminder of why that p-value is important. And those moments, there's not just one of them. It happens, you know, sort of sporadically throughout the time as I'm reading these, throughout the day-to-day of work. But when I find one comes in and it's, you know, really descriptive, it's such a beautiful pause and reminder of, like, you know, why I'm, you know, knee deep in spreadsheets, or, you know, like crafting emails, or, I don't know, talking about more minutia. So those moments are really special too.
I love these two pieces next to each other. It's like the extremes. Like, what's going to go to the FDA is like a data set devoid of all of this. But at the end of the day, it's people whose like lives are fundamentally being changed. And it's really powerful. Thank you so much for that, Alia.
Yeah, I love, you know, both of those perspectives. It's great to have like the PhD and the MD side by side, so we can be reminded of, you know, all that it takes to like make these things happen. It's really awesome.
Yeah, and I was wondering kind of if you guys might be able to describe what really happens while people are taking this therapy, and why is it so transformative, do you think?
So the logistics of what's happening, I think, is, you know, good to go over. So when people are doing MDMA-assisted therapy in our treatment modality, they come in for a day long of therapy. They're in a living room like setting, as I was describing, with two therapists who they already have a little bit of a relationship with. You know, kind of practically speaking, they come in around 9 a.m. They check in with each other, and then if everything's good to move forward, then they take the medication somewhere between 9 and 10. And then the setting is set up so that there's a comfortable place for the person to lay down. And it's encouraged that person sort of lay down, have eye shades on, and be listening to music on headphones. So that way they're really focused on sort of their inner landscape, and less on the people in the room with them or the particulars of the room. The music is a playlist mostly chosen by the therapist or the therapy team to sort of follow the arc of the MDMA experience and help be evocative of like sort of the feelings and things that will come up for people as the drug effect goes on for them. The peak of the drug effect is about 90 minutes after it's first ingested, and people are taking it fasting in our studies. So they fasted like from midnight the night before. And at that 90-minute mark, we check in with them, or the therapists check in with them, see how they're doing, if they weren't talking, if they were laying down, and then administer an additional half dose of the medication, as long as it seems like a good idea, which is assessed in a lot of different ways. But most people take that other half dose. And then the whole day lasts somewhere between 6 and 8 hours. The drug effect without the supplemental dose is like 4 to 6 hours, and then 6 to 8 hours with that extra half dose. So that's sort of like, what does it look like? And people pop in and out of being with their eye shades on and their headphones on, and it's really session to session and person to person varies a ton. So some people are out talking a lot and really want to use the therapist to help facilitate what's going on for them. And some people are like laying down with their headphones and eye shades on the whole time, and a lot of variation in between that. It's encouraged though for them to try to spend some time inward again, so to just really kind of understand what's coming up for them. The therapy is considered sort of non-directive, meaning the therapists don't have specific questions that they're going to ask or directions that they want to take the patient in, that whatever's naturally coming up for the patient inside them, that to trust sort of that wisdom of what we call the inner healing intelligence, which, you know, I say now like it's no big deal, but I remember when I first heard it thinking, what is that woo-woo terminology in med? I've never heard that in med school. But it's just to trust that whatever comes up for people is what they need to be thinking about or processing. So then in terms of like, how does the drug work and what is it doing? Allison talked a little bit about this, and, you know, like, people are I think people who know a lot about neuroscience are really interested in like, what are all the different neurotransmitters, and we could, you know, there's a lot of schematics and papers on that, but I think the important part is that really the feeling for the participant, which is that there's an openness to look at things that sometimes are much more challenging or difficult or scary to look at and to approach. That fear kind of, it's not that they're not aware of it, but it melts away and it becomes easier to look at things, not necessarily at the first time, in terms of like, they're not going to look at the most grueling, horrible thing at the first time, but that they may be able to approach whatever's coming up with more openness and empathy for themselves, empathy for the others who were involved in the situation, that there'll be less of that trigger of fear, trauma, or other things that come up, and then this allows them to kind of see where they need to go to understand their process better and how they've come to arrive at who they are now. And as we've mentioned several times, this is really this is a sort of a catalyst or a spark that helps facilitate a different kind or a way of approaching therapy. But really, it's not so different than like 8 hours of therapy without the drug, except it just kind of opens things up in a new way. Mm-hmm. I don't know, Allison, if you have more you want to add about the neurotransmitters or anything.
Yeah, I was about to ask.
Yeah, I mean, so some of the animal research suggests that one of the things that MDMA could be doing is really enhancing fear extinction by triggering this oxytocin-dependent critical period of enhanced neuroplasticity. So by having this, psychological state where you have increased trust and decreased reactivity, and then being able to face these traumatic events in your past, and having MDMA facilitate the fear extinction and memory reconsolidation, we think these are the mechanisms by which it allows the support of MDMA to really enhance the therapeutic process in a way that is durable and sustainable, and that it's not, okay, we're just having this conversation about this hard thing, but it's creating new pathways that actually allows it to stick with you. And then importantly, as Alia was saying, following this day of the MDMA therapy session, there's also integrative therapy that follows it, where they can kind of continue reinforcing these pathways. So I think that that's, generally we know that's really important for neuroplasticity, is to continue, following the same pathway. So I think these integration sessions that we do that follow the MDMA assisted therapy sessions are actually incredibly critical to it working the way that we've seen it.
Definitely. And I think this is why in our phase 2 studies, we found in long-term follow-up that people are even better than they were at the 2-month follow-up. Even though it's farther time since they took a drug, it's that integration is so critical. And as people integrate, as these new neuronal connections continue to fire, and they're in practice of that, they continue to get better and better. So we're hopeful that our phase 3 data, long-term follow-up data, will demonstrate that as well. But we're actively collecting it right now.
Exciting. As far as indications, what is MAPS looking at next? Is the plan to move on to other disorders now for this MDMA therapy?
Yes, PTSD is certainly the dominant program that we're doing right now for a lot of different reasons. We're the farthest in it, and if it gets approved, as I mentioned sort of in the beginning, there'll be a new source for funding because we'll be able to sell drug to then support our other research as opposed to relying entirely on philanthropy. So there is some push to get it past the finish line for one indication so that we can start pursuing the other ones. But we also know that the path towards regulatory approval is long, and that we want to be starting the other ones concurrently, so that way they're not too far behind. We do have a program for eating disorders, which is starting soon. And that's one we've gathered a little bit of data on from our phase 3 studies, and just for people who have PTSD, keeping track with some measures on how it's changed their eating patterns. And then, so that study is up and coming, I think, in next year. We have still within PTSD, but studying a group model of care. So we're not just looking at different indications, but different delivery methods. Like, is there a way to do group MDMA-assisted therapy to help with sort of the affordability related to having 2 therapists sit with 1 person versus maybe 2 therapists with 5 people? And with that, I'm curious, like, is there enhanced efficacy because people gain community? A lot of these mental health diagnoses, people will characterize as lonely diagnoses, that people aren't connected and feel a lack of community. And just like other support groups have demonstrated a lot of success for people suffering from there's something that they gain actually from the support of the group that's in this modality of therapy.
I'm really excited about the group study. I think that is going to be one of the big path forwards for a lot of these different types of therapies. So actually collecting data to show, this is something that we can do is a huge step forward in patient access.
And then MAPS has a really robust investigator-initiated trial program where we're not providing the funding for the research, but we help sort of shepherd investigators along the way through development of their protocols and acquiring drug and all of the sort of hurdles that are unique to a Schedule I drug research to help for lots of different indications. So that is where sort of we participate in so many different things. Ben Sessa in the UK has published on alcohol use disorder with MDMA-assisted therapy, showing promising early results in a small group of patients. And one that I'm super interested in is opioid use disorder in postpartum women. And so that's one that's IIT that's up and coming. But they're like 100 and some, there are tons.
Wow. So I had a question about how can we kind of make the psychedelic research more approachable to society, and like how can we make it progress faster in terms of removing hurdles for your guys' research?
Oh, that's hard. I think those are really two very different questions. The progressing faster is often, definitely the pandemic set us back a bit. And as Alia said, since we are completely donor funded, has been one of the big hurdles, trying to be able to move as fast as we'd like, have the staff that we'd like. I think any big pharmaceutical company hearing what we're doing and the scale of our phase 3 trials and the number of staff that we have, it's phenomenal that we've been able to get this far, and we're only increasing our staff in the last few years as we're gearing up for approval. Sorry, what was the first question?
So the first question was more around like getting support from the
landscape.
Yeah.
I think about this a lot, as I keep saying, what the public perception is. I really believe that there has been a lot of, I feel like I said this already, but a lot of mischaracterization about the risks and benefits based on this scheduling and the public perception. And so trying to publish data to be able to change people's minds. I don't know if that's the most effective tool to change people's minds. We do have, MAPS has the policy development arm. They're working on that, a lot of harm reduction. So, the MAPS arm of our company, it has very different goals. They're all aligned, but I guess very different mechanisms towards the same goals, I should say. Instead of pursuing the clinical drug development model, they're, out in the community doing these policy initiatives, harm reduction initiatives. And we're hoping some of that might, impact. We actually are starting some programs in other states as different state legislatures are starting to do more harm reduction initiatives in their, public groups with their law enforcement. We're supporting these types of initiatives to try to, make this more public and educate.
What do you mean by harm reduction?
It's a term that I'm constantly trying to think of what's the best way to describe this, but harm reduction, people sometimes say risk reduction. It's how can we help maximize the benefits and reduce the risks in any particular situation. The way we way we really talk about it is in this context is if people are choosing to engage in various different drug use, how can we help ensure that they have whatever kind of education and materials they need to decrease the risk of those substances. So the most, I think, common one that people talk about, not related to MDMA, is like clean needle exchange for heroin use is an example of a harm reduction model. How can we ensure that if people are doing it in a healthy and safe way? So there are other examples with opioids, but for MDMA and MAPS, we have a whole arm of MAPS called the Zendo Project, which maybe you're familiar with, but
yeah,
it
was one of my last questions that I was going to ask about. So I'm glad you brought it up.
Yeah, so Zendo Project, I think people commonly think of it, they go to festivals and are kind of like next to the medic tent, where if you're having a hard trip, bad experience, but there's nothing medically going on wrong with you, then you can come to Zendo, and there will be people there who have kind of similar training to our therapists. I mean, they're not trauma specific and PTSD specific, but still the same kind of model of supporting people through feelings and thoughts that come up while they're on psychedelics, and help them have a safer and more comfortable experience. And so these are volunteers, and what this often looks like is sitting and talking with people, just helping people through their hard time by getting them something to drink, having them have a comfortable place to be, someone to talk to or bounce ideas off of, someone to kind of hold the space for them so that they know that if something comes up, that there's someone else who will keep them safe and help them process things. So that's a lot of what we talk about in psychedelic medicine for harm reduction, is how can we train people who are going to be the first responders to someone in a psychological crisis on a psychedelic, to approach them from that kind of mentality, as opposed to like they need to be restrained, or they need to be taken to the ER. Sometimes they do, depending on what's going on medically, but sometimes there may be better environments or ways of dealing with the situation, so that people are safe and comfortable and while they're on their psychedelic experience.
The idea behind the approval of these psychedelics is not kind of like marijuana, where you can go to a dispensary. It's more probably a facilitated kind of environment where it's only being given under prescription or something like that. Is that the idea?
That's exactly what our expectation is, because we're not developing this as a standalone drug that here you take this drug and it lowers your blood pressure, like that type of medication. It's developed as an adjunctive therapy. Our expectation is if the FDA approves it, it's going to be approved as an adjunctive therapy. So it does, this is part of what I find so interesting about the regulatory landscape. The FDA has not approved something like this before. They regulate and approve drugs, but they don't regulate the practice of medicine or behavioral health practices like psychotherapy. So developing these combined treatments is really a leap in thinking for the typical clinical development.
That's interesting. I hadn't thought about that.
Yeah, there are a lot of concurrent legislative measures to decriminalize these medication or these drugs, and even the word that you use, medication, drug, substance, molecule, it's different settings are maybe more appropriate for different drug names. That's why I switched. But yeah, there's a lot of legislation in lots of different states now to promote the study of them, to decriminalize them, and some legalization, and so there are parallel journeys: the journey of legalization, decriminalization, and then the journey we're taking of regulatory approval, that maybe have some of the same goals of understanding and safe and legal access, but are really different in the sense that if this drug gets approved, it'll be like any other prescription medication that a doctor will assess someone and determine whether it's safe and appropriate for use, and then they'll write a prescription. And then the way it's different, as Allison said, is that we anticipate that it'll be a drug that's taken in a particular setting. But there are other kind of similar-ish models of that. No one does chemotherapy at home. People do it at the hospital or the setting where people, even that, as I say that, I realize that's actually not true. But
I'm curious if you think, how much you think that the IP around some of these molecules inhibited its progress. And I'm just thinking about that with respect to, you know, funding a clinical trial, but it being something that you can't necessarily hold on to as like your own IP, right?
Mm-hmm. Yep. That has definitely been part of the challenge. The FDA gives 5 years of data exclusivity for things that don't have a patent on it, but that's all that we'll have, which is why I was saying that a lot of these for-profit companies are hoping to develop new small molecule compounds. Some companies right now are also trying to, there have been attempts to patent different aspects of psilocybin-assisted therapy.
Really?
Some of the different techniques in the therapy. The patent field is very interesting. You can file for patents for things, and the PTO might even grant patents for things, but you don't really have them until they're tested in court. Like, you can have a patent, right, but if somebody sues you, it's really, you don't know what the outcome is going to be until that's tested. So we do look at some of these patents as a little bit extreme. They don't seem like things that they would be patentable. So I think that more and more companies are trying to develop things that are clearly patentable by making new small molecular entities.
What are your thoughts around that type of strategy? Because I'm just thinking of the situation with ketamine. And if I understand correctly, you know, ketamine was showing really great efficacy for treating depression. And there was a push to try to identify like a similar molecule, but that one didn't work as well, you know, in the studies. Are you in support of people doing that? Or do you think we should stick with the like tried and true molecules and just, you know, all work together to get these clinical trials done and move this into, you know, greater use?
I think it's a tough question because at the end of the day, maybe it's the doctor in me, I'm most focused on do people have access to things that are going to make their lives better? But I think the process is important because it impacts access. And, you know, one of the things that MAPS is very proud of is that even as we head into this ambitious goal of commercialization, that we're remaining a nonprofit, not taking investors, because it's hard for that the investors and that sort of desire to please certain people by making money for them to not influence how you do things. That instead your customers kind of become your investors as opposed to the patients that you're trying to help. It's one of the huge challenges of healthcare in this country, I think, in general, because health insurance is, you know, not something that's nationally supported and guaranteed in the way that it is in other places. And so healthcare in general, the customer is rarely the patient, but that's the person whose life matters and who needs help and wants to get better. But that being said, you know, I want them to be available. And so it's a hard road what MAPS is doing. It's a really hard road. And there's a reason why other psychedelic research organizations have decided to go the investor route, because it's easier to raise money if in that field and doing it that way. And that's why people are trying to come up with new molecules and patent them. The other side of this that is a really interesting debate is if a new molecule was developed that sort of minimize some of the things that make these psychedelic drugs sort of a bad trip or like the negative effects. And I put that in quotations because a lot of people feel like the negative things are important things to understand about, you know, and why you're having a negative reaction to them. For example, psilocybin, some people feel really nauseous ingesting mushrooms or psilocybin. Would it be better to make a new molecule that never made anyone nauseous? You know, standard medicine would say yes, like that's a good thing to do. We would want to avoid that. But there are a lot of people, in particular the indigenous cultures, who've been using psilocybin as part of they're healing in communities for a long time that think these tweaks on the drugs, you're losing some quality to them, an important part of the journey and the experience, which is, which teaches you something. So I always hold that in balance too. Like, what is good to get rid of, or is that a bad way of thinking about things? It's not really the psychedelic way of thinking about things. The psychedelic way is to, how can you learn from the bad things?
Interesting. Well, I think we can wrap up. I know our time is almost up. So did either of you have any last comments, or if there's anything that, our listeners can help MAPS or MAPS PBC with, such as recruiting or getting people into the training programs or donating to your nonprofit efforts, feel free to share that now if you'd like.
Yeah, those are all helpful things that our program needs. All of the information is on our website, maps.org. We appreciate everybody's, involvement and interest in our studies. You can also sign up for the newsletter. We put out a monthly newsletter and bulletin that give you a lot more information.
Awesome. Yeah, and I think, this is a plug for you guys too, but share this podcast, like, continue the conversation, share it with someone that you don't think would normally listen to this. Like, this progress that we're talking about happens, we're all just individual humans. It happens human by human.
One conversation at a time.
Yeah, one conversation at a time. So have the conversation. And
absolutely. And that's kind of part of what this, what inspired the podcast was, like, sharing these types of conversations with others and bringing people into the conversation. So I really appreciate both of you taking the time and, working with us as we get the panel style interview set up and everything. And I think it was a great conversation, and so many interesting things came to light for me, and I think Alex too. So really appreciate it.
Yeah, it was great to talk with you both.
Yeah, and please feel free to anyone listening to visit maps.org for all kinds of information. We're very open science. You can see our protocols, all information about the drug, everything on the website. And if you have any questions, there's an Ask MAPS email address, which does get answered. So
yep, we all help answer the questions. It's
really. I love that.
Sweet, I should submit some.
Yeah, I'm sure Alex has even more questions. She really was kind of the inspiration behind this episode, and I'm appreciative that she could join and share her curiosity with you guys. So awesome. Well, we'll get the edit taken care of, and probably in a couple days send you guys a link for you to review, and any feedback is welcome. And then we'll try to publish the episode in about 2 weeks. So give you guys some time to review and everything. I know people have busy schedules.
Perfect.
Appreciate that.
Thank you so much.
Thank you. This was awesome.
Thanks for all your questions.
Of course. Bye, guys.
Bye, guys.
Bye.
That wraps up our interview with Alia and Allison. Thank you so much for taking the time to teach us about your beautiful and exciting work at MAPS PBC. I learned so much. I hope that you, as our listeners, also learned a lot. And thank you again to our sponsor, Kendall Investor Relations. If you enjoy our content, please subscribe, give us a like, or leave a comment. I really appreciate it. Thanks so much for listening. See you next time.